So this will be a talk on lung cancer. And lung cancer is the most common cause of cancer death in the United States, both in men and in women. And lung cancer is a highly preventable cancer. So this is pretty significant from a public health standpoint. It is also the second most common malignancy overall, both in males and in females. In men, the number one cancer is prostate, and in females, the number one cancer is breast. But it is the most common cancer as far as cancer deaths. Most commonly, lung cancer presents in older age, between 60s and 80s. It's not a disease of younger people. This is something that has a very high association with smoking, and in the U.S., virtually all the cases of lung cancer we see are in smokers. It's also associated with asbestos exposure. Asbestos can actually increase your risk of cancer, lung cancer, by 75 times. So that's pretty significant. And then radon gas exposure is another contributor. So usually lung cancer has a poor prognosis, and that's because by the time it causes symptoms, it's usually late in the course. Now, sometimes lung cancer can be detected just due to a chest x-ray that's done for another reason. And those tend to be the cases when people survive lung cancer because they don't have symptoms yet, and you see the nodule and you work it up, you find out it's cancer, but it's early on in the course. That doesn't happen very often, though. Okay, so lung cancer. In patients with lung cancer, smoking is associated with these patients. So not all patients who have lung cancer are smokers by any means, but smoking is associated with all forms of lung cancer. So if you smoke, your risk of all lung cancers, all four of them, which we're going to talk about, is increased. Also, occupational exposure, like radon and asbestos. The symptoms of lung cancer when it presents symptomatically are cough and dyspnea, and then of course weight loss. Now, weight loss is a unique symptom. Cough and dyspnea are rather nonspecific, but weight loss is a symptom of cancers in general. So whenever we have pulmonary symptoms plus weight loss, we are thinking lung cancer. Now, another thing that it could be would be tuberculosis, particularly if the patient has a fever. But that's not very common in the U.S. So if you have a history of smoking and you've got a patient that's older, has cough and dyspnea with weight loss, you better be thinking lung cancer. Fatigue and hemoptysis are slightly less common. Hemoptysis, though, is significant because it does happen in almost a third of the patients. Chest wall pain, bony pain, and neurologic symptoms are also symptoms. Chest wall pain would be particularly if it is a peripheral tumor, and bony pain, of course, would be if there's metastasis. Neurologic pain or neurologic symptoms is usually associated with the syndromes that occur with small cell lung cancer, which are paraneoplastic, and that would be Lambert-Eaton myasthenic syndrome. So usually, if there are neurologic symptoms, it'll be weakness, but it's not incredibly common for it to present this way. Other neurologic symptoms could be seizure, altered mental status. That correlates with brain metastases. So the symptoms you should know for lung cancer are cough and dyspnea, shortness of breath, weight loss, of course, and then hemoptysis. On physical exam, signs consistent with shortness of breath will often be common, so use of the accessory muscles of breathing, and then lymphadenopathy. Other things you may see if it's later on in the course would be signs consistent with chronic hypoxia, so pursing of the lips or clubbing. You may also note chest dullness to percussion, and that would be a sign of an effusion. For diagnosis, the best initial test is going to be a chest x-ray. So some cases, as I mentioned, are incidental. You get the chest x-ray for another reason. Say you think the patient has pneumonia, or you're looking, you want to look for a broken bone or something, and you run into the nodule. Some cases are incidental, but most of the time the patient does present with symptoms, and it's later on in the course. Findings that are consistent with lung cancer as far as looking at the chest x-ray would be a new lesion not seen on other x-rays performed within the last 2 years. So when you see a nodule, let's say that you did the x-ray for a different reason. You did the x-ray because the patient fell off a ladder and you think they broke a rib. You get a chest x-ray and you see a nodule. How do we know if the nodule is benign or malignant? Well, we don't know just based on the chest x-ray alone, but there are some findings that can give us hints. First of all, if it's small. Smaller nodules tend to be benign. So less than 1 centimeter in diameter, they tend to be benign. More than 1 centimeter in diameter, they have a higher risk of being malignant. So benign lesions also often have calcifications, they're often dense, and they're often very homogeneous looking. Smooth margins are also consistent with a benign lesion. And then of course, if you have a nodule that is also seen on another chest x-ray that was done more than 2 years ago, that's very consistent with a benign lesion. Malignant lesions tend to be bigger. They tend to be more heterogeneous in appearance, so you'll have variable density and variable calcification, irregular margins, and also it'll be new or enlarged or changed from an old x-ray that was done, I should say, less than 2 years ago here. And then pleural effusions in the presence of a nodule are also consistent with a malignant lesion. So here's a benign nodule, and this is at the periphery of the lung, but you can see how it's small, it's very circular, and very regular margins, and quite homogeneous. Here's a malignant nodule, it's slightly bigger. You can see that it doesn't have that homogeneity. There's some calcification, but it's more calcified in some parts than in others. And most importantly, though, is that it's larger. Now, of course, you're also going to be thinking of the patient's history. So if the patient is a smoker and they have a nodule, then that raises the risk of a malignant lesion. If they're 75 and they have a nodule, that increases the risk of it being malignant. So you have to take into account the patient's history as well. So the differential of a solitary pulmonary nodule, so let's say you just see this nodule, it may not be cancer, it may be something else. So you have to think of things other than benign or malignant nodules. So it could be a hamartoma. A hamartoma is a benign nodule of sorts, but it's a particular type of benign nodule. So these, of course, would be like a benign nodule would be in non-smokers and in patients who are asymptomatic. On CT or on chest x-ray, it tends to have this popcorn ball appearance, and the CT will illustrate that much more clearly. Granulomas also tend to happen in non-smokers, and they tend to be asymptomatic, and this will have a bullseye nodule appearance on chest x-ray or on CT. Tuberculosis can also appear as a solitary pulmonary nodule. Tuberculosis tends to be in immigrants, patients with a known exposure to tuberculosis, or in patients that have a positive PPD or Mantoux test, and patients who have a fever. If there's calcification or it's less than 2 centimeters, that also increases the likelihood of it being a tuberculous nodule. And then a miliary pattern on chest x-ray, and that's that CD-like pattern that you see particularly in symptomatic TB patients. But for the USMLE, I would know that if they have a positive PPD test and a nodule, that's more than likely tuberculosis. And then fungal infections or Mycobacterium avium complex, you tend to see in HIV-positive patients with a low CD4 count. And usually this does not present as a solitary pulmonary nodule, but they present in multiple different loci. So how do we work up a solitary pulmonary nodule? Well, first off, when we see that solitary pulmonary nodule, we look at how it appears on the chest x-ray. Does this look like a benign lesion? Does it have nice smooth borders? Is it smaller than 1 centimeter? Is it clearly benign? We have to combine this, though, with the history, with the symptoms, if there are any present, and old chest x-rays. We come to a clinical conclusion. If it's clearly benign, you can do a follow-up in 6 months, a year, or 2 years. If it's clearly malignant, then you're going to have to get a biopsy. If it's questionable, which usually we don't ever go to clearly benign, usually we go to questionable because there is a liability aspect. If it's questionable, then you can get a CT, and that's going to be much more accurate than the chest x-ray. So if it's questionable, go ahead and get a CT, and if the CT says that it's likely benign based on how it appears, then you can go ahead and follow up in 6 months, get that chest x-ray, and see if there's any change. If the CT says that it's likely malignant, then we're going to go ahead and get a biopsy. How do we get a biopsy? We either get it by flexible bronchoscopy or by fine needle aspiration. And which approach we take depends on what kind of tumor it is. So a lung tumor can be either peripheral or it can be central. If the tumor is central, we can access it by bronchoscopy. If it's peripheral, then we access it by fine needle aspiration. Because think of central being closer to the airways, then we have to go in with a bronchoscope because we can access the tumor that way. But if it's peripheral, we're going to have to go from the outside in. All right, and then if the biopsy says it's benign, then that's pretty much it for your workup. You can consider all other diagnoses, and you know it's not cancer if you get a benign biopsy. Remember, biopsy is the most accurate test for diagnosis. If it comes back as malignant, then you're going to have to assess the patient for treatment. Other tests that can be done, but usually don't come up as the right answer on the USMLE because they're neither the first test nor are they the most accurate test, would be a sputum sample. So a sputum sample can be done if the chest x-ray or the CT indicates that it's a central lesion. And a sputum sample is pretty good at detecting squamous cell lung cancer, but the others, it's not as good at detecting. So it can detect squamous cell lung cancer pretty good. It can detect small cell lung cancer pretty good, but the others, not so much. But certainly, if you get a sputum sample and it comes back positive for squamous cell lung cancer, then indeed, you can make the diagnosis right there. A thoracentesis with cytology is good to do if the patient has an effusion, but not all patients are going to have an effusion. Video-assisted thoracoscopic surgery would be a secondary test that we would do if we do that initial fine needle aspiration, but we can't get at the tumor. So the VATS, all it is you're going in with a video. It's kind of like, you can think of it kind of like how we do laparoscopy, except we're doing it in the thorax. And we can get at the lesion, at the tumor that way. And then another thing that's done sometimes is if there's any kind of lymphadenopathy, you can get a fine needle aspiration of the lymph node to see if there's cancer in that lymph node. So once you've diagnosed lung cancer, you need to get routine laboratories. Those routine laboratories are going to include CBC. CBC is useful because if there's any kind of cytopenia, that can suggest bone marrow metastases. If you have bone marrow metastases, it's going to decrease your production of platelets, of red blood cells, of white blood cells. So cytopenia can suggest bone marrow metastasis. CMP is useful as far as electrolytes because it can detect SIADH, which is a paraneoplastic syndrome associated with small cell lung cancer. LDH is useful because it can detect bone metastasis, and of course if the LDH is elevated, that indicates that there probably is bone metastasis, and that is an adverse prognosticator. Liver function tests are useful. Those are included in the CMP. They suggest liver metastasis if it's elevated. For imaging, you're going to want to have a CT if you haven't done it already. Usually, though, you will already get a CT before you go ahead with the biopsy technique. And that CT is going to be needed for staging. You're going to get a brain MRI because you want to check for metastasis. And then skeletal radionucleotide imaging is useful to check for bone metastasis, which isn't, you're not able to detect on MRI. You can also get a whole body MRI to detect for metastasis to other tissues. But you're always going to need the CT and the brain MRI at the very least. So this is a malignant pulmonary nodule. You can see it's larger. It does have rather smooth margins, but just the fact that this is very large is ominous. Another thing is that it's so central to the airway. So this is around the level of the bifurcation to the right and left bronchus. So this is very central. Here's another one. This is, it looks like there are 2 lesions here, but this one is very, very large. And you also see some lymphadenopathy here. This is also central. When you're thinking of what central is, central just means close to the large airways. And then here's another one that's central. Again, you see multiple foci. And then you see the lymphadenopathy here. Okay, this is a peripheral lesion. It's smaller, but you can see that the border is a little bit more irregular, and then you also see lymphadenopathy. This is another peripheral tumor. This is a particular kind of tumor, and you can tell just based on this that it's an adenocarcinoma. And the reason you can tell that is because this is what's called a Pancoast tumor, and you probably remember that from step 1. And Pancoast tumors are always adenocarcinomas, and they always occur on the upper lobe of the lung, either on the left or the right. And this one happens to be on the right. And it's associated with neck and shoulder pain and brachial plexopathy, which is just an impingement on the brachial nerves, which provide innervation to your arm. And then it's also associated most notoriously with Horner's syndrome. And Horner's syndrome is ptosis, which is the drooping of the eyelid, meiosis, which is a small pupil, and anhidrosis, which is the inability to sweat on that side. Okay, so here's another peripheral tumor. And again, this is really big. So you know just based on that size that this is going to be a malignant nodule. So as far as differentiating the types, you don't really need to know how to differentiate them because this is going to be done on biopsy, and there aren't any biopsy questions on step 2 or 3. You're not going to have to look at any pictures on step 2 or 3. What you do need to know, though, is what types of cancer are central, meaning we're probably going to be able to access it with bronchoscopy, and which lesions are peripheral, meaning we're probably going to have to access it with fine needle aspiration. So the central lesions include small cell lung cancer and squamous cell lung cancer. I'm just going to start out now by saying that you can categorize lung cancers in 2 different ways. You can categorize it by their location, whether they're central or peripheral. You can also categorize it by small cell lung cancer and non-small cell lung cancer. If you're a surgeon, you're probably going to use the central versus peripheral classification. If you're an oncologist, you're probably going to use the small cell versus non-small cell classification. So the central lesions include small cell and squamous cell lung cancer, and the way I remember it is small cell and squamous cell are central, so you've got that alliteration there. So small cell is central, and small cell Lung cancer is associated with rapid metastasis and a very strong correlation to smoking. They all have a correlation to smoking, but particularly small cell and squamous cell have very strong correlations to smoking. And then small cell lung cancer is also associated with paraneoplastic syndromes. So those syndromes include Lambert-Eaton myasthenic syndrome, which would manifest as weakness, and then SIADH, which of course is going to be manifested as high blood pressure, as low sodium, high potassium because of the disordered secretion of ADH. I did a whole talk on ADH if you go look at the renal section or the endocrine section. Squamous cell lung cancer has a strong correlation to smoking as well. You also can see on the X-ray, squamous cell is more associated with cavitation than small cell is. And there is a paraneoplastic syndrome associated with squamous cell lung cancer, which is due to the fact that squamous cell cancers tend to secrete a protein that's similar to parathyroid hormone, and indeed it actually works the same way as parathyroid hormone. So it increases your serum calcium, but your PTH, your actual PTH, is going to be low because your calcium is high, and that's suppressing the parathyroid glands, and you get less PTH secreted. What this is parathyroid hormone releasing, or parathyroid hormone resembling peptide, PTHrP. So it doesn't actually show up on your labs as PTH. So your PTH will be low and your calcium will be high. But that's going to be due to the fact that you're secreting this other protein that looks like PTH. Okay, and then the peripheral cancers include adenocarcinoma and large cell lung cancer. Adenocarcinoma is the most common lung cancer in patients who are non-smokers. Adenocarcinoma is the most associated with pleural effusions, and it is the one that when Pancoast tumors are there, it is an adenocarcinoma. So adenocarcinomas can present as Pancoast tumors. They are Pancoast tumors when they're there. And that's associated with Horner syndrome. So if you have a patient with Horner syndrome and a lung tumor or a lung lesion, then it's usually adenocarcinoma, and you know that without even looking at the biopsy. Large cell lung cancers are associated with cavitation, but there's really not much else special about these that you'd be able to tell from adenocarcinomas. They're just peripheral. That's how you can tell them from the other ones, but otherwise you can't really tell these from adenocarcinomas. So just remember, small cell and squamous cell are central. Peripheral include adenocarcinoma and large cell carcinoma. And also know the paraneoplastic syndromes, Lambert-Eaton and SIADH with small cell, and hypercalcemia with squamous cell. Okay, so this is a nice diagram which you can find on Wikipedia, and this indicates the percentage of lung cancer that each type comprises. So adenocarcinoma is the most common, and it also happens, that's also the most common in non-smokers. So about 50% of lung cancers are adenocarcinomas. Small cell is about 25%. Again, you see here, very few people are non-smokers. Squamous cell is about 20%, and large cell is about 8-9%. So remember that adenocarcinoma is number one with non-smokers, and then the other ones make up the other half. How do we treat lung cancer? Well, that's going to depend mostly on whether the tumor is a small cell cancer or a non-small cell cancer, and whether the tumor is central or peripheral. And it's also going to depend on the patient's stage. So you don't need to know how to stage the cancers for the USMLE, but you do need to know how to tell if the cancer is central or peripheral, and you need to know whether the tumor is a small cell lung cancer or a non-small cell lung cancer. So if it is a small cell lung cancer, the treatment is chemotherapy. And the chemotherapy we use for small cell lung cancer is carboplatin and etoposide. We always use a platinum-based chemotherapy for lung cancer. There's always a platinum-based chemotherapy in the treatment for lung cancer, no matter what kind it is. But for small cell lung cancer, we use carboplatin and etoposide. Now remember that carboplatin, you could use carboplatin or cisplatin, basically the same thing. Carboplatin is has a little bit fewer side effects. Carboplatin and cisplatin both have a level of nephrotoxicity, cisplatin more than carboplatin, and then there's also a level of ototoxicity associated with the platinum agents. So carboplatin and etoposide, chemo alone for small cell lung cancer, no surgery. For squamous cell lung cancer, again, really no surgery. You generally, really always can't, you don't really do surgery for the central cancers. So for squamous cell lung cancer, it's chemo and radiation. Now, squamous cell lung cancer, remember, is a non-small cell lung cancer, so we do a different regimen for squamous cell lung cancer. Remember when I said that usually oncologists use the small cell lung cancer versus non-small cell lung cancer system? This is why. So for the non-small cell lung cancers, which is anything but small cell lung cancer, for non-small cell lung cancers, we use CAP chemotherapy. CAP is cyclophosphamide, adriamycin, and a platinum agent. So cyclophosphamide, adriamycin, and a platinum. So cisplatin or carboplatin. And then we can also do radiation for squamous cell lung cancer. Now, for the peripheral lung cancers, it's going to depend on the stage. So if you caught it early on, which is very rare, but if you caught it early on enough and it's a stage 0, then you can do surgery alone. If it's stage 1, you do surgery and radiation. If it's stage 2 or 3A, you do surgery, radiation, and chemo. So you can see how we're building up here. If it's 3B or 4, the definition of 3B and 4 are that it's disseminated. And the problem with dissemination is that, well, we can't do surgery because the tumor is in too many places. So 3B and 4, we just do radiation and chemo. And usually these patients pretty much never survive. But 0, 1, 2B, and 3A have a decent shot at survival. Obviously, it's going to be less the higher stage it is. And any kind of chemotherapy in non-small cell lung cancer, remember, you use your CAP. Cyclophosphamide, adriamycin, and platinum. For small cell lung cancer, you use carboplatin and etoposide. Now, if you're going to do surgery, which you can do in the peripheral cancers, but if you're going to do surgery, then you need to assess the patient to see if they're eligible. So not all patients are eligible. The way you assess them is by pulmonary function tests. So the good rule of thumb is if they have an FEV, this is, I didn't put that there, but this should say, this is FEV1. So if they have an FEV1 of greater than 2 liters per second, in general, that means they're eligible. If their FEV1 is less than 1.5 liters per second, then in general, they are not eligible. But it's a much more complicated calculation. You don't need to know it, but this is your rule of thumb. So it's the FEV1, and if it's greater than 2 liters, they're eligible. If it's less than 1.5 liters per second, they're not eligible. And the reason that we take this test is because we're going to be taking out their lungs, and we need to make sure that they have enough lung function that when we take part of their lungs out, that they're going to be able to survive on that. So the more lung that's taken out, the higher the FEV1 ratio should, or the FEV1 should be for the patient to be eligible. So if the patient is sitting right at 2.0 and you're going to be taking out their whole left lung, they're probably not eligible. And so, I'm sure there are guidelines for all of this, but just know this sort of rule of thumb, and know that the more lung that you're going to take out, the better their FEV should be to make them eligible. And the different kinds of resections that are done are wedge, segment, lobe, and then unilateral pneumonectomy. So wedge is just where you're taking a little bit of a piece of a segment. Segment is where you're taking a whole segment of a lobe. The lobe is where you're taking off a whole lobe of a lung. Remember, the right side has 3, the left side has 2. And then unilateral pneumonectomy is where you're taking out the entire left or the entire right lung. Okay, so these are some other tumors that I just wanted to show you because I alluded to them earlier. So these are all benign, but a hamartoma has what's called this popcorn ball appearance. You can kind of see it with the with the chest X-ray, but really this is kind of a when you look at this, you'd think, man, this kind of looks malignant. It looks like almost a central malignant tumor, and so you'd want to get that CT. If you simply just see this, you probably want to get a CT. But then when you look at the CT, this appearance is very typical to hamartomas. Here's another hamartoma. This one's quite small. Oops. And then here's another one up here. But another way that you can kind of tell it's a hamartoma is that you've got this sort of calcification on the inside. Okay, now granuloma is very, very easy to tell when you get a CT, and it's this bullseye lesion. So you've got calcifications on the outside and then on the inside. This is a granuloma. Here's another granuloma right here. And this one's actually attached itself to the chest wall. And then here's another one. This one's smaller. So no, hamartoma being popcorn ball lesion and granuloma being a bullseye lesion. More than likely on step 2 and 3, you're going to be given that term, that buzz, one of those buzzwords, as opposed to an actual picture, because they're not very easy to tell, particularly on chest X-ray. So that should be pretty much good for lung cancer. If you have any questions, let me know.